Siddhama, we can share.
Yes, sir.
Yeah. Please start.
Yeah. Good morning, respected faculties and all my colleagues. Today I am presenting a case on undescended testis. So, patient particulars. Patient is named X and 1 year of age, who is a male resident of Kolkata. The mother brought the baby to the ER, to the OPD with the complaints of empty right scrotal sac since birth. History of present illness. The patient is apparently well with an empty right hemiscrotum and a normally developed left scrotum since birth. There is no associated history of any trauma, no other visible swelling in the inguinal region from the loin to the inguinal canal to the root of the penis or anywhere in the scrotum, and there is no visible bulge on cuffing or straining. Antenatal history. The mother has been on regular follow-up in the antenatal period, and there has been no history of any maternal diabetes, no history of smoking or alcohol intake by the mother. Perinatal history. This is birth order 1 for the mother, and the baby is a term baby. It was delivered by lower segment cesarean section, and the birth weight of the baby was 3.2 kgs. The baby is exclusively breastfed till now and is immunized up to date. Family history. There is no history of similar illness in any family members. And treatment history, the patient had no previous treatment history for the same issue. So summary of the case, the patient is a 1-year-old male who was brought to the OPD with chief complaints of empty right hemiscrotum. There is no associated trauma, pain over the right inguinal region, or any other visible swelling on bilateral inguinal region. There is no bulge visible on crying or straining. Antenatal history is not significant. The baby was delivered by lower segment cesarean section with birth weight of 3.2 kgs, and there is no significant family history. Sir, should I proceed?
Okay.
Yes, sir. So should I? Okay. Proceed with general examination. So general examination. General examination. The baby is examined after taking informed consent from the mother in a well-lit room with proper exposure. The child is conscious with good cry, well nourished. There is no visible pallor, icterus, sinus clubbing or edema. Vital signs. Blood pressure was about 90 by 60 millimeter of mercury, and the pulse was taken from the radial pulse. It was measured 106 per minute, and respiratory rate was 22 per minute, and the patient was afebrile. Anthropometry, the weight of the baby was about 9 kgs, height was about 70 centimeter, and mid-arm circumference was measured 12 centimeter. Inguinoscrotal examination. On inspection, a normal left hemiscrotum with testis was seen, and maldeveloped right scrotum was seen with which was visibly empty. There is no associated inguinal bulge bilaterally in any other region, and the penis appears normal. Palpation. There is normal temperature over the scrotum and no temperature over, no tenderness over the inguinoscrotal region. On left side, the testis of about 2.2 centimeter was palpable in the left hemiscrotum, and on the right, an empty hemiscrotum was seen. A firm nodular structure was palpable between the superficial and deep inguinal ring in the inguinal canal of about size of 1 into 1 centimeter. The penis is normal with normally situated urethral meatus, and there was no bulge in the inguinal region while crying or straining. Systemic examination. The respiratory system had bilateral equal air entry. Cardiovascular system had normal S1, S2 with no murmurs. Central nervous system was normal, had normal findings, and musculoskeletal system developed, no abnormalities were detected. In the gastrointestinal system, per abdomen was soft, non-tender, and non-distended. So summary of the cases, 1-year-old male was brought by mother with chief complaints of empty right hemiscrotum and no associated pain over scrotum or any other associated swelling in the inguinoscrotal region. There is no inguinal bulge visible on crying or straining. Baby had a term delivery with a birth weight of 3.2 kgs and there is no significant family history. On local examination, an empty right hemiscrotum was seen with palpable nodular swelling of about 1 into 1 centimeter between the deep and superficial inguinal ring and no associated inguinal hernia. Systemic examination is normal. So my provisional diagnosis is a right-sided palpable undescended testis.
Okay, go back to the first slide of history of present illness. Madam,
Yes.
Madam, we can start. Madam, you are muted. Okay.
Am I audible now?
Yes, please. So these are histories as given, but I think it's incomplete. Just you see has written only 3 lines in history of present illness. So it should be a little more exhaustive.
Okay, sir. Sir, what is?
You have to write in the history of present illness whether patient had any painful swelling, or because the child is only 1 year old, so he will not be able to complain of pain. Whether the
Yes.
parents ever experienced any painful swelling in the inguinoscrotal region which subsided on its own, because undescended testis is many a times associated with trauma which presents as a swelling, and patients at that time do not seek any medical advice and it undergoes atrophy on its own. So
Yes, ma'am.
soon after birth, there was any swelling in the inguinoscrotal region which was painful, lasted for 2-3 days and then disappeared on its own. That's a relevant history. And as I pointed out, whether mother had any history of progesterone intake during her pregnancy. Dr.
Ma'am,
Shah,
there
if you
is
think.
no history in the treatment history.
Madam, no, go back to the history of present illness. Yes, here also, this patient who is 1 year old, you have to ask some question to find out whether he has got any other congenital anomaly. You should at least ask whether he is passing
Yes, sir. Okay, sir.
because some associated anomalies with this, whether he has got any bending of the spine. Okay, so there may be some vertebral anomalies. So then these are all common anomalies. Whether he has got any respiratory stress, and cardiac anomalies.
Yes, sir. Yes.
Apart from the presenting complaint, you should ask some question to find out whether he has got any other congenital anomalies, which are very common with these sort of genital anomalies.
Yes, sir. There was nothing present in this patient, sir. I just did not mention it in this. Yeah. Hello. Hello, sir. Hello, sir. You are not audible, sir.
Other part of history is all right. Come to examination.
Yes. Yes, sir.
Local examination. Local examination. Yeah. Okay. Then on inspection, that swelling you are describing, there is no bulge in the inguinal canal.
No, sir.
Okay. So that you mentioned specifically that no swelling is still in the.
Yes, sir. Sir, I said bulge. Probably I should use swelling as the word.
Inguinal bulge bilateral. Okay, fine. Next palpation.
Yes, sir.
You try to understand, in a 1-year-old child, the inguinal canal has not developed. The deep ring and superficial ring almost are superimposed.
Overlapping each other. So you cannot.
So you cannot say that you find something between deep ring and the superficial ring. You can at least say that there is a swelling inguinal region. There is
Inguinal
no
region. Okay, sir.
different inguinal canal in a 1-year-old child. Okay.
Okay. Yes, sir.
So you
Is
find
the
one by one.
swelling, Sritama,
Yes,
is
madam.
the swelling always palpable, or it comes and touches your hand only when the child is straining and then goes back on its own? Because in that
Ma'am, it was
case,
very small, so it was palpable, ma'am. It was not, the baby was not crying at that moment when we palpated.
it's so it is present there when the baby is crying and when the baby is quiet, both
Quite,
the
yes,
occasions, because
yes,
there's
ma'am.
a differentiation. If it comes on, if it touches your hand only when the baby is training, then it is called emergent testis.
Emergent
And
test.
the, yeah, and if it is always there, if you can palpate, then you will have to do a maneuver called bringing it down to the normal pathway,
Yes,
whether
ma'am.
you can, you
The
have to
gliding
occlude
test.
the
The
deep
milking.
inguinal ring.
Yes.
You have to occlude the inguinal ring with your left thumb, and with the right thumb, you gently try to bring the swelling
Milk
down
it down
in its
through the
normal
inguinal.
pathway,
Yes.
if it can be brought towards the scrotum.
Scrotum. Yes, ma'am.
Did you do it?
Yes, ma'am, we did it. I did it also on my own. And ma'am, it was not like coming down. It was like, it was
When
just
you
little,
palpate the
it was
testis,
movable
Pritama,
along the inguinal, like in along the pathway of the testis descent, but it did not come down to the scrotum.
okay. Sitama, when you palpate the inguinal canal, I
Yes, sir.
can assume three possibilities. One is it is a retractile testis, which often comes to the scrotum and go back to the inguinal region. Number one. Number two, it can be a incomplete descent, which the testis is lying deep to the external aponeurosis. And third is it can be ectopic testis. How you differentiate these situations? Why not say retractile testis? What will you
Sir,
find in a retractile testis?
sir, in the as according to mother's history, the patient never had any. The patient always had a left empty right hemiscrotum,
And
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 uh,
and
and
also you
also
find the hemiscrotum
the scrotum was
is
maldeveloped. It was had decreased rugosity, so it was not normal in shape as like the left
yes
one.
developed. You can find the scrotum is full. Okay, so
Yes,
the
sir.
hemiscrotum seen the testis in the scrotum anytime, so it is unlikely to be, and you cannot brought the testis down to the
To
scrotum.
the scrotum.
So can it be a ectopic testis in this location?
Ectopic testis, we have to differentiate by the rising test, leg rising test.
That is difficult. I understand. In 1-year-old child, it is difficult to do. So,
Yes,
but
sir.
you should keep in the possibility that a location in this site may also be a ectopic testis.
Yes, sir. Superficial inguinal pouch is one of the locations.
Yeah. And have you examined the spine? Have you examined the
Yes, sir. There was
anal
no,
canal area?
sir. There was no associated
Systemic.
in the
So they,
spine.
you
There was
should
no.
keep in mind a patient with a congenital anomaly, you should exclude other congenital anomalies, and you should say that there is no other clinical.
Yes, sir. This baby had no other congenital anomalies. There is no associated vertebral anomaly or meningomyelocele or any of that that is associated with undescended testis, sir. We did a full examination, but actually I just forgot to mention that.
What other congenital anomalies are associated with undescended testis? Can you name a few? Like
Ma'am,
you said, vertebral anomaly and
ma'am,
meningomyelocele,
gastroschisis or omphalocele
or
and
any abdominal ventral hernia. Whether
abdominal
there
hernia.
is difficulty in rise in intra-abdominal pressure, which is an important factor in the
Yes,
descent of the
in the
testis.
descent of testis.
So,
Yes, ma'am.
if there is any abdominal hernia, which other regions did you palpate apart from superficial inguinal pouch to look for an ectopic testis?
Well,
In
ectopic
other,
testis can be located in the of opposite scrotum in the root of the penis. It can also be located on in the perineal region and
and even
one
to the anterior superior iliac spine of the same side.
yes,
These
ma'am.
are the other regions which you'll have to palpate to look for an ectopic testis.
Yes, ma'am.
Root of the thigh, perineum, opposite scrotum,
Opposite
and
scrotum.
same sided anterior superior iliac spine.
Yes.
You have
Okay.
mentioned in your physical finding that the pelvis is normal with normally situated urethral meatus. Usually in a 1-year child, the prepuce is physiologically adherent. So
Yeah.
you should, instead of mentioning it as normal, you should mention that the penis is is normal in appearance as well as the physiologically adherent prepuce. By retracting it gently, the urethral meatus could
Yes,
be
meters
seen.
can be
That
seen
means
as it
it
is.
has
Yes.
a pattern emerged.
Okay.
So
Come
your
to
next slide.
diagnosis.
So diagnosis is a right-sided palpable undescended testis.
No, should be
No,
little more specific. You wanted to say that you have palpated the testis in inguinal canal.
inguinal canal. Yes, sir.
So, palpation से है. Madam,
So
is this all right or
Right-sided,
she should be more specific?
right-sided
yeah,
palpable
right-sided palpable inguinal testis.
Yes.
And you
inguinal
say
testis.
inguinal
Okay.
testis, that means it implies that it is undescended.
Okay. Okay. Inguinal testis.
Right-sided undescended testis, testis being palpable in the inguinal region. That you can say. At least that makes a feel that you will be able to palpate the testis and probably testis has gone beyond the deep ring and it is
Yes.
palpable.
Yes, sir. Yes.
Okay.
How do you manage your case?
Sir, ma'am, first we should be doing ultrasonography of the bilateral inguinoscrotal region, and that way we can detect. We might be able to detect the testis in the right inguinal region as we have palpated, and once we have confirmed the location of the
No,
testis.
ultrasonography examination, you will have to elaborate more. USG examination
Yeah.
of
In the undescended
bilateral
testis, you try to tell
inguinal
us what you look
Yes.
for.
We have to look for any associated ectopic inguinal swelling, or we have to look, and we also have to look for the position of the right testis, sir.
What in testis here is important to be assessed ultrasonographically because you are going to do surgery in this patient.
Sir, we have to check the site and the size of the testis. If it is
And
significantly smaller than the normal
1
testis.
centimeter is still acceptable size of the
Yes,
testis in a
yes, sir.
1-year-old child.
Yes,
What
yes,
else
sir.
you should look for
Sir, we have
in
to do a
ultrasonography?
Doppler to see the
Yes,
vascularity.
yes, that is important. Whether the testis
and
having normal vascularity. Okay.
whether there is any associated hernia with the
Hernia, yes.
undescended testis or not. Presence
Yes.
of hernia.
Sitama, if I
Yes,
put a scenario that the thing you are palpating is probably not testis and the ultrasonologist cannot make out anything in the inguinal canal. So
yes.
sonographically, one possibility is testis in the inguinal canal. Second possibility is ultrasound cannot pick up that 1 centimeter lesion and they cannot say it's a testis. So is the scenario same or scenario will change? Ultrasonographically, no testis in the inguinal canal. Ultrasound, testis in inguinal canal with normal vascularity. Will your approach change?
Sir, if there is no testis visible by ultrasonography, then we have to assume it's an intra-abdominal testis, and subsequently we have to go with a diagnostic laparoscopy, which is uh, which will help us confirm if it is an intra-abdominal testis, and from there we have to do the testicular mobilization.
Let's go back to your ultrasonography examination. We were not finished there yet. You haven't mentioned anything about the opposite testis.
Opposite testis, ma'am. Opposite testis. It was located in the scrotal sac. So
But you will have to ask your sonologist to examine both the inguinoscrotal
yes,
region
bilateral
with the size of
inguinoscrotal
the
region.
opposite. Yes. And
Bilateral
what other what other ultrasonography examination do you order? Just ultrasonography of bilateral inguinal region is it sufficient? No. As
No,
sir
but
was mentioning, at least you will have to do an abdominal ultrasonographic examination
to check for
to
any
find
ventral
out
hernia.
whether ventral hernia is visible to you, whether there is any associated genitourinary tract abnormality, like common as being the same-sided kidney being absent. Patient might have renal agenesis on the same side or any
Yes.
other abnormality like UG obstruction, hydronephrosis or hydroureteronephrosis. So you'll have to order an ultrasonographic examination of genitourinary tract, that is kidney, ureter and bladder. Especially if there is no swelling palpable in the inguinoscrotal region, you will have to ask your sonologist to look for ultrasonography of the retroperitoneal region. Sonologist will not be most of the time able to pick up, but if there is an associated renal anomaly, you need to find out. Okay, proceed with rest of the examination. You need to perform any other. Whenever you answer in question, you will have to answer questions in exams. You will have to specify the to confirm your diagnosis, the investigations that you shall be doing, and for management, for operative purpose to find out whether the child is suitable for undergoing examination under general anesthesia, you'll have to perform some investigation.
Yes.
Divide. So what
So
are any other, suppose the sonologist cannot pick up any swelling, right or left, whichever I forgot, right-sided, any swelling in the inguinoscrotal region. Will you go for any other examination?
ma'am, we have the option of doing CT scan and MRI, but that is more often not detected.
Testis
Like,
palpable
CT
inguinal
scan has
canal,
got
go for CT.
sir,
It take your
CT
no,
case.
sir.
scan has
Try to understand.
For localization of impalpable
No.
testis.
Your patient is palpable. You find a patient palpable, ultrasound you have done, ultrasound corroborated finding, then I don't think you should order a CT or MRI
No,
for
sir.
this patient.
No, okay, sir.
even if
Even
it is
madam,
not palpable,
do you do CT or MRI for a patient who has got a likely internal testis? See the routine?
no, sir, I do not do MRI because for a 1-year-old child,
Yeah,
it is
they cannot be in
very,
the MRI gantry. Very difficult.
yeah, they cry so much, anesthesia for that, and until and unless you have done a diagnostic laparoscopy, you are not
Yeah.
sure about where the testis is. So
Yes, sir.
why undergo
So
an
I'll
unnecessary
feel that don't
examination?
say CT MRI. Let examiner ask you something, but don't utter that I'll do CT or MRI for assessment of a patient who understands testis will be impalpable. That is not standard of care.
Yes, sir. We will do a diagnostic laparoscopy, sir.
Yes, you say that. I know. You say CT MRI is there in the book. There are some situations people can advise, but sensitivity is not very high. MR has little more sensitivity than CT scan. Agreed. But doing MR in a 1-year-old child is a difficult job.
Yes.
Okay. So any other investigation? Any other investigation? Baseline workup?
Sir, in other investigations, sir, for this patient, sir,
Yes. You have confirmed the diagnosis with ultrasonography, and then he needs an investigation to assess his fitness.
For gene
yes,
fitness,
sir,
you
we
will
have to
need
do the routine blood investigation, sir, for fitness of anesthesia and surgery.
Only
it is
blood?
better not to
And
utter
sir,
the word
ECG, chest
UG.
X-ray, an ECG, chest X-ray, and serology.
Will you go for echo? Will you go for echo?
Ma'am, for 1-year-old patient, ma'am, we are not doing echo regularly.
That depends. If you have some evidence of cardiac disease,
Yes,
suspicion.
sir. This patient was normal, sir.
Yeah.
So tell us about the operative management. You have found swelling in the inguinoscrotal region. So will you still go for diagnostic laparoscopy, or which approach will you use?
Ma'am, once we have confirmed once we have confirmed the presence of testis in the inguinal region, we'll proceed with an open orchidopexy on the right side.
Which kind of anesthesia will you prefer? Will you go anesthetic? Will you ask you how much time will you require? Not more than half an hour. So let's go for TIVA. Will you go for TIVA?
No, ma'am. We are using general anesthesia for pediatric patients.
Why is a general anesthesia? You must have an endotracheal intubation.
Endotracheal
Anesthesia with
intubation. Yes.
intubation, because the child's muscles should be completely relaxed, and before you go for your approach, you palpate the abdomen and the inguinal region under anesthesia properly, whether the swelling which you could find during the clinical examination is still there, and you have a suggestion that it is a testis-like structure, so you will go for exploration of the inguinal region. So what will be your incision?
So incision is over a groin incision parallel to the inguinal ligament. So skin crease
As
parallel
I
to
said,
the
the inguinal canal here is very short, almost superficial ring, and deep inguinal ring is superimposing on each other. So
Medially, how do you start? Medially, where the incision start? Medial point of incision?
Is it oblique along the inguinal ligament, or is the incision
No, ma'am, it is
transverse?
for children, ma'am, it is on the skin crease. It is not oblique. So we start between the ASIs and the pubic tubercle in the midpoint. We start the from there medially. We go lateral.
Okay. So what structures do you encounter?
So first we encounter after the skin, we go through the subcutaneous fat, the campus and the scarpa fascia, and then we encounter the external oblique aponeurosis, and it is incised. After that, we can expose the inguinal canal. And so after exposing the inguinal canal, if there is any associated inguinal hernia, we have to do the herniotomy at this point. After doing the
How do you
herniotomy,
identify if there is the testis, and which structure you have to identify first? Before even if you embarking on doing anything to the testis, you have to find out
we
that
have to,
structure first.
spermatic cord, we have to
No, ma'am, you'll have to find out the gubernaculum, which is
gubernaculum, yes.
attached from the lower pole
Lower
of
pole
the
of the
testis
testis. Yes.
to the base of the scrotum. So you have to identify the gubernaculum first, and you have to divide the
With the
gubernaculum from its
gubernaculum.
central attachment, making very sure that you have gone to the extreme of the gubernaculum, because many a times there is an associated long loop vas. The vas passes alongside the gubernaculum for to some extent. To avoid injury to that, you will have to pull the gubernaculum as far as possible and divide it as distally as possible, making sure that you are not dividing any other structure. You will have to locate the gubernaculum first. And then after dividing the gubernaculum, if you put traction on the gubernaculum, then you can milk the testis down. Then there comes the question of identifying the structures of the spermatic cord and the patent processes vaginalis along with it. Okay, proceed.
Okay.
How will you?
So we after dividing the gubernaculum, we have to identify the spermatic cord, and then we have to mobilize the testis and the spermatic cord after dissecting the premenstrual muscles and the fibers around it. After doing a complete mobilization,
Ma'am, you haven't seen an operation being done. There are many operations in YouTube. You should see. After identifying the testis, you will have to evert the tunical sac. You will have to open the tunical sac and evert the testis. Then, under direct vision, using very sharp dissecting scissors, as far as away from the inguinal canal, you will have to look for the processes vaginalis and separate the structures of the spermatic cord under direct vision. You'll have to evert the testis first. And whether there is a palpable hernia or not, you will have to, the processus vaginalis is always there. So under direction to separate the structures of the spermatic cord and ligate. If you start the dissection very close to the inguinal ring, which is already very short, and the peritoneum is very friable, then there are chances of tearing the peritoneum. The tear might extend to the beyond the inguinal canal. Then it becomes very difficult to repair. So try to divide the processus vaginalis as far as away from the inguinal ring as much as possible. Then you look for the other structures which is holding the testis back, and difficulty in mobilization of the spermatic cord arises. One is cremaster and the others.
Ma'am, the difficulty in mobilization can arise due to short testicular vessels also.
The testis which is palpable in the inguinal region usually have normal.
Yes, ma'am. This person did this one did not.
I asked any other region where you will have to do the dissection, like on the lateral aspect of the spermatic cord and the testis. There are small fibers which is attaches the spermatic cord on the lateral aspect near the inguinal ring. You will have to divide those. Suppose still you cannot bring it down beyond the superficial inguinal ring or the beyond the pubic tubercle. It's coming to the root of the scrotum. Any other maneuver that you can do, any other structure that you can divide to bring the testis down?
Ma'am, we can incise the fascia transversalis and medial to the medially, and then we can dissect the cord structures high up, and that way we can bring the cord structures down directly.
Any
But there are
important
few
vessel
options.
that
There are
will
few
divide
options.
and medialize the spermatic cord.
Yes.
A vessel that you have to divide
Ma'am,
and medialize
division of
the
the
spermatic cord.
inferior epigastric vessel.
Yes, inferior epigastric
Medial
vessel.
displacement can be done.
And still the testis cannot be brought down to the testis. What else can you do?
Ma'am, we can do a Fowler-Stephen procedure.
No. That part is gone. You have left that sail. Ship has already sailed.
You are
If
close
want
to superficial ring. Try to
to-
understand. You are close to
Okay.
superficial ring.
Why
At
do
this
you
point, you may not divide. Fowler Stephen has got his own complications. 50% chance of atrophy.
can do
Ma'am,
laparoscopically.
we
What
can
else?
we can do a two-stage orthopexy also.
No, ma'am. You'll have to, whatever you do, you have done extensive dissection. Now you cannot do anything to these spermatic vessels. Any other maneuver, what is called Prentice maneuver.
Prentice.
You can invaginate the scrotum and fix it to the lower end of the testis, so that the testis will be slightly higher up in the than that of the left side, the opposite side, but it can be fixed to the bottom of the scrotum. The scrotum, you have to do an invagination. That's called Prentice maneuver. And suppose your mobilization is perfect, there is no tension in the spermatic vessels, then how do you fix the testis in the bottom root in the scrotum? How do you do it?
Ma'am,
How?
we make us, ma'am, if after the proper mobilization is done, we put a small incision of about 2 centimeter to 2.5 centimeter on the scrotal skin, and from there we make a space in the subdartos space between the skin and the dartos fascia,
And then
and then we put an artery forceps on from the scrotal skin. We inserted an artery forceps and we make a small incision on the dartos. From there we insert the artery and pull the testis down into the subdartos pouch. After that if the neck as the neck is small, we do not need to fix the testis. We just close the skin scrotal skin over the testis. But otherwise we have to put an anchoring suture around the testis on the neck. And we also have other methods of anchoring if this is not adequate. Hello?
Yeah, madam, you are muted.
Never put a bite on the testis.
No, never
You
put a
narrow the sac of this subdartus pouch, but
Yeah.
never put. You can put an anchoring stitch. That's why you have to divide the gubernaculum as low down as possible. You can put a bite in the gubernaculum, but never put a bite to the testis because that hampers the blood testis barrier and might
Infertility also.
future problems of infertility. Okay. What are the, and then you reconstruct the inguinal canal. Some people advocate, since I said the inguinal canal is very short,
Ma'am, you are not audible.
some people advocate not opening the external oblique aponeurosis, but the operation gets very difficult. So for proper dissection, for an examinee like you, I'll always advise that you open the inguinal canal and then proceed with your operation. Am I audible?
Yes, ma'am.
Yes.
What are the complications of this operation?
Uh,
Complications you should always classify as early and delayed. What are the early complications? What are the delayed complications?
Ma'am, early complications can be hemorrhage and infection, and late
Hematoma formation, wound infection, and
late complication, ma'am. These even after orchidopexy, there are chances of infertility. There is chances of devascular.
One side, right, left side is
D.
normal. Do you think
Yes, the
patient
other
has
side is normal. It's very
No, sir.
unusual that the patient
Yes.
will have infertility.
this for bilateral? Is infertility is for bilateral cryptorchidism.
So it can there can be
Normal common thing.
devascularization.
What can happen? Subsequent follow-up, it can atrophy.
Yes, sir. Atrophy for devascularization. Either vascularization or not
This
atrophy.
can
Any other
ascend if
complication?
there is,
Other
if there
complication.
is
Yes, ma'am.
first delayed complication is ascent of the testis. There was traction on your spermatic cord, so you might have fixed it at the bottom of the scrotum, but
Yes.
it can ascend. Parents
Yes.
will complain that after operation it was at the bottom of the scrotum, but now I can palpate it at a higher up situation.
Yes.
So it
Yes.
can
And ma'am, it can
ascend and
there
then
can also
chance of atrophy.
there can be atrophy, and there can also be malignancy of the testes in later period as a orchidopic, and as a undescended testis still has a chance of conversion to malignancy even after orchidopexy.
So that's why the parents should be asked to for a regular follow-up of the child. Yes, but after orthopexy, as early as 1 year old, development of
Yes.
malignancy
It's not.
is far less than
Yes.
if it was intra-abdominal. Suppose this testis was not palpable at all, it was an impalpable right-sided testis. So what will be your approach? You said diagnostic laparoscopy. So can you elaborate on your port insertions? Where will be your port?
Ma'am, port will be in infraumbilical port, and
You are working in the inguinal region. So how can you have infraumbilical port? It will have to be supraumbilical port. For a 1 year old
Optical
child,
port.
whether you
Optical
use
port, supraumbilical. Optical port,
port
5
should be
millimeter.
supraumbilical.
Okay. Go with
Whether
the 5
you
millimeter
use it
telescope.
2 millimeter or 5 millimeter, the length of the instrument is same for all. So you must have a supraumbilical port will be the optical port, and the other two working ports will be
on
along
ma'am,
the umbilical line, both on right side and the left side. So after you have inserted your port, what will you do? You have inserted all the ports.
ma'am,
Where
first.
will you look for the test? Where will you
First
look
is
for
looking
the
at the
test?
deep ring.
Yes,
First
you
is
have to
looking
see.
at the deep ring. What you
Yes.
can see in impalpable test is looking at the deep ring, you get the next decision. What do you look at the
Ma'am,
deep ring?
so looking at the deep ring, we can see if the cord structures are passing through the deep ring, And
Yes.
if
and the ring is closed.
ring is
If the
closed,
cord,
yes.
so if the cord structures are passing through the deep ring and the deep ring is closed, that means testis is somewhere in the scrotal region.
Yes,
And if the ring is open and you do not see
no
the
visualization of cord structure.
vessels, then where do you look for the testis? Intra-abdominal testis, where will it be?
Ma'am, it is found. We have to just trace it below the deep ring, and we can see the testis in the intra-abdominal region. Just
Most
below
commonly
the
near the deep ring. Most commonly
Which
near
other
the deep
structure?
ring. Where do you
Which
go?
other
What is
structure
the
will
line?
you have to retract?
we have to. Sir, I could not get you, sir.
Where do you find? Deep ring closed is a commonest site. You are
Yeah.
not finding closed deep ring. What next area you search? Next area. At what line and what structure need to retract? It's on the right side.
Oh, other structures.
If you think of the line of descent of testis, so you have to start looking at the line of descent.
Line of descent from the loin to the from the lumbar region to
Loin
the.
means what? If you are intra-abdominal, loin means what? From intra-abdominal
Which
aspect?
structures will have to mobilize or retract? First, you look behind the bladder. Many a times the testis is behind the bladder. If it is not there, then you retract the what do I say? Retract the cecum and the ascending colon, because behind that lies your renal testicular vessels, which is originating from the. Where does right testicular vessel originate from, and where does left testicular vessel originate from? Both testicular arteries originate from the কলসিতমা যাতে জিজ্ঞেস
Yes, sir.
করবে
Yes, ma'am. Testicular artery, ma'am, uh, arises
As
from
from
uh,
aorta.
no,
No what?
yes,
It's from
from
the
the
aorta only.
abdominal.
from the
It's a
aorta.
At what
It's
level?
only the vein. It's only the vein which has got different drainage.
Yeah.
Yeah,
The left
it's from
side
the
it drains into the renal vein.
renal
Right
At
vein.
what
side
level? At what level the artery gets come from the aorta? At what level? It is L1, L2 level.
Okay, sir.
And vein, madam said, vein has got a different termination. Right side, left side.
So right side is from the IVC.
From two.
Right
Right
side
side
is
is
to
from
IVC
IVC.
and left side is to
Left is to the
renal
gonadal vein. Renal vein. Renal vein.
So
Yes.
you will have to reflect the the cecum and ascending colon to the opposite side, and you have to look in the retroperitoneum for the right testis. How do you know whether you will need at this level? You will have to decide whether this patient needs Fowler-Stephens technique, or you can perform a diagnostic laparoscope. You can perform mobilization and bring the testis down. How will you decide that whether your length of this spermatic vessel is adequate or not?
Ma'am, we have to.
Laparoscopically. You have mobilized. Now you can say, yes, I have done good mobilization, it will go. What do you do?
Ma'am,
If you're not
Sir,
sure, you cannot answer
she
that.
has to decide before mobilization. She has to decide before mobilization. You have identified the testis. Which maneuver will you perform? After that, you decide that yes, my length will be adequate for bringing it down, or no, my length will not be adequate. I'll have to go for Fowler-Stephens. Which maneuver?
Ma'am,
You identify the gubernaculum, the same thing. You identify the gubernaculum,
yes. And we have
and
to
with
put
your
a traction
laparoscope put traction and
and
take the
then
testis to
take the
the
testis towards the
opposite inguinal canal.
opposite
Towards
inguinal.
the opposite
Yes.
inguinal canal. If you can do that without much of a tension, then you know that you have got sufficient. In that case, you can go for mobilization of the vessel, which is the golden triangle, which you should not interfere during mobilization. The golden triangle.
Uh,
The vas goes to the bladder, and the testicular vessels along with the testis goes towards the inguinal canal.
yes.
So you should not dissect between the testicular vessel and the spermatic cord and the artery to the vas. This region you should not dissect. Whichever maneuver you do, you have to do lateral mobilization of the peritoneum on the lateral aspect of the cecum, and then you have to deflect. And if you have to do Fowler's defense technique, then do not do any dissection at all. You just
divide
clip the spermatic vessels, not divide. You just clip. Where? Where do you clip it? Where? There are two school of thoughts. You can clip it either close to its origin from the aorta, or you can clip it at the upper vessel, upper bowl of the testis. What is the rationality behind the Fowler's defense? That it will develop collateral circulation from the artery to the vas and other vessels from that region. So during that stage, you do not do any kind of mobilization or any kind of dissection at all.
Yes.
But as said, there is Fowler's defense has got its complication. There are 30% of chances that the testis will atrophy.
Yes.
So when will you do Fowler's defense second stage? Usually after months.
6 months.
3 months. Usually after 3 months. Okay. Waiting till 6 months is not going to do any kind of going to give any advantage to the patient. To the second stage and 3. That time you again have to do a laparoscopy, do your dissection and bring the testis down.
Yes.
Madam, little about testicular development and descent. These are also asked in the exam.
So Sritama will tell me what are the. I was thinking of rather asking about, had it been bilaterally impalpable testis, what will
Okay,
you
yes, please. Yes. It's a bilateral undescended testis, not palpable.
Okay. So bilateral impalpable testis, during investigation, we can also add hormonal investigation, like for.
Is genitalia important? In bilateral undescended testis, is genitalia examination very important?
Yes, yes, sir, because it can be congenital, congenital adrenal.
It can be disorder of sexual differentiation. Disorder of sexual differentiation, whether the penis has got normal development or if there is any associated hypospadias. Hypospadias of proximal variety like perineal hypospadias and bilateral undescended testis, you will have to think of whether the patient is male or female. You will have to go for karyotyping. Both testis palpable and perineal hypospadias or penostotal hypospadias, you will have to go for karyotyping. So this
Sritama,
is the only.
How is karyotyping done? Sritama, how is karyotyping done? What do you do? Why do you send the patient?
Sir,
we are sending patient often to this department. This is done in the genetics department. Initially it was done in science college. What they do? What do you test? Simple, very simple test. You take buccal scrap. You take a scrap from the buccal mucosa, and from there they can do the genetic analysis. What they see? What are you trying to find out? Madam said karyotype.
If it's a genetically male or a genetically female.
Yes. Okay.
You look for bar body on the buccal scraping. You look for bar body. That bar body is the inactive X chromosome in a genetically female. That is 46X. Can also be seen on the neutrophil. The buffy coat of the serum has got neutrophil. The bar body you can see there, but the bar body demonstration is not foolproof. There is a 20% gray zone area. So these days they go for 100 cell karyotyping, which is done from. You need actively dividing live cells. So that will be, I think, a little more elaborate for them. But karyotyping is
important. What else now?
What other hormonal tests? You mentioned hormonal.
We have to check for HCG, FSH, and ma'am, if there is
LH
high FSH
and
and Mullerian
no, ma'am,
inhibiting substance.
Yes, that
and
is important. Okay.
MIS and
Yes,
baseline serum testosterone level. Then you do
yes,
HCG
testosterone.
stimulation test for 3 consecutive days at the rate of 100 international unit of beta HCG per kg. 100 international unit per kg. You will have to inject for 3 consecutive days. Then after 48 hours, you again estimate the serum testosterone level. If there is a 20-fold rise in serum testosterone level from the baseline, that means your patient has got testis somewhere in his body which can be stimulated by the beta HCG. This is called FSH surge test, and this is diagnostic more or less that you have your patient still has got functional testis.
Yes.
So what do you do then?
Ma'am, so if we have confirmed that there is testis present, then we have to go for diagnostic laparoscopy in this patient.
You will have to go for diagnostic laparoscopy even if your FSH surge test does not show any rise, because you cannot
Yeah,
declare
we
the
cannot declare
patient is
that patient.
anarchic without performing a diagnostic
Yes.
laparoscopy. And it is very unlikely that a patient who is genetically a male, that is 46XY, you will not be able to see any testis intra-abdominally, because your purpose is not to leave any testis in the abdominal cavity.
Yes.
Suppose you have got both testis bilaterally very high up with short testicular vessels, what can you do? You have got every facility available. Can you do anything else? You can perform microvascular transplant.
Like ma'am, silver procedure.
Pardon?
Ma'am, the silver
Silver,
procedure for
microvascular.
dividing the dividing the testicular vessels and then reimplanting testicular artery with the inferior epigastric artery and the
Yes,
vein with
yes, you can do that. So
yes.
whatever you do, you will have to bring the testis in a palpable situation. You cannot leave any testis intra-abdominally. And
Yeah.
even those testes are very small and the patient may not be fertile, but it produces some hormones so that the patient's growth, the skeletal growth and development of other sexual, secondary sexual characters can be achieved. So it is not advisable to remove bilaterally very small testes with short testicular vessels. You get my point?
Yes.
So, so that future malignancies can be detected, the testis should be brought to the normal position. And now, sir's question, tell us about few
What are the
lines
indication
about
for orchidectomy,
development.
madam? When
हाँ,
you
ठीक है.
resort for orchidectomy in undescended testis, what is the indication for orchidectomy?
Sir, if there is a atrophic testis,
Before that, if there is a torsion, torsion
yes.
infarction will dictate a orchidectomy.
Yes.
And
What is if there if even after applying all methods of mobilization we cannot take the testis down to the scrotum?
And you have the other testis already in the scrotum. Then you can
atrophic
discuss
testis.
with the
Yeah.
patients and can with the parents and can go for orchidectomy. But in that case, do not forget that you will have to fix the other testis at the bottom of the scrotum so that the healthy testis does not undergo torsion. Suppose this was a neonate, say 1 month old with an inguinal testis associated with torsion, what will you do?
Ma'am,
This is a
if it
take
is
home.
associated with torsion, we have to explore, and if we can find that the testis is viable and the vessels it's still viable, then we have to do an orchidopexy. But we
And opposite side?
we have to do a
So in
orchidopexy.
that case, you will have to perform
Bilateral orchidopexy.
undescended testis many a times is associated in neonate with strangulated hernia also. So if you will have to explore, reduce
Yes.
the strangulated hernia, do an herniatomy and do the orchidopexy at the same sitting, because you cannot leave the testis in the inguinal region, because then it will form lot of adhesions and it will not be possible. It will be very difficult to do an orchidopexy later. So these are the indications when you operate on a patient with undescended testis even in the neonatal period. If it is associated with torsion or if it is associated with strangulated hernia. In neonatal phase, that is within 1 month of life, an undescended testis is associated with these two complications. Suppose a neonate is brought to you with this complaint. This patient, instead of coming at 1 year of age, had come to you at the age of 7 days. That one side testis is not palpable. What will you advise the parents?
Ma'am, if the baby is a full term baby, then we have to advise the patient parents to wait for 6 months, because by then the development will be complete and this descent of testis will be complete. And sometimes even after that, if there is no improvement, then we have to proceed for surgery. And for if it is not a term baby, if it's a preterm baby, then we have to wait for at least 1 year to check for the complete development.
Actually, a testis which has not descended by 3 months will not descend. But we do not go for orchidopexy at that early age, because the vessels and the vas are very fine. Plus, the child has not received all its immunizations and it's still in the growth period. So experts, those people who are doing orchidopexy only, like Dr. Hudson in Australia, he performs orchidopexy as early as 6 months. But we, the pediatric surgeons, generally advise to perform orchidopexy at the age of 1 year. So your answer is correct. That we'll for a term baby, we'll have to wait for 6 months. If the testis has not descended, we'll have to go for orchidopexy. And for a preterm baby, actually we have to calculate the gestational age. Suppose
Yes,
the
yes,
child is born 1 month earlier, so you add that 1 month to your 6 months. So you'll have to
yes,
wait for 7 months.
yes.
Sir, I think we'll have to proceed
Yeah, we
towards
are
for
covered.
day's
Just
work.
few things about the
Sitoma,
development. Yeah, just
few
few
things about
questions.
the development.
In the retroperitoneum, that at 4th week of intrauterine life, 3 thickening develops. One is pronephros, one is mesonephros, one is metanephros.
Yes.
What is the fate of these 3 structures? What happens to pronephros in human being?
Uh,
Simple, one-line answer.
Pronephros, sir, it obliterates, sir.
Disappears.
These are
What happens to
okay.
mesonephros?
So then mesonephros forms.
In the male, in the female.
Yeah.
Yeah. Mesonephros forms the
That's
So,
difference in the male.
mesonephric tissue, so understand, mesonephric tissue disappears. Mesonephric duct
mesonephric
persists.
duct forms the vas deferens and the epididymis.
And in the females?
What happens to metanephros? Yes.
Uh, in the female, sir, ma'am, that forms
Forms the Mullerian structures.
Mullerian
That
structure.
is the
Yes.
fallopian tube, uterus, and upper third of the vagina. And what happens to the metanephros?
Uh,
Simple.
Metanephros form the kidneys.
Ma'am, the
But
Yes.
complete
Kidney and
ureters are
ureter.
formed
you
ureters are formed as an outpouching from the mesonephric duct, and it ascends and joins the metanephros. Actually, the bladder of trigone, this is also formed from the mesonephric duct. So that's again the anomalies like
So
ectopic ureter.
why from the testis develops? Tell us. Why from the testis develops? There are a lot of things in sexual development.
the testis also develops
Find the
from
thickening.
the genital ridge.
Yes.
And it's at the genital ridge from the mesonephros, which is
Yes.
in the
Right.
posterior
Where
abdominal.
from the cells, germinal cells come to the testis?
Spermatocytes or germinal cells. Those are
Uh,
called primordial germ cells. How do they
Yeah.
reach the mesonephric ridge?
Where from they arises and where they reach.
the germ
These
cells,
cells
one, sir, okay, primordial germ cells,
they're from the primitive yolk sac.
primitive yolk sac, yes.
Okay.
They
And
migrate
when
from
the
the primitive yolk sac.
and as the testes are developing, it forms a fold of peritoneum in the retroperitoneum. What is that fold called as?
Sir, processes vaginalis.
No, no, no.
No. That's called
Retroperitoneal thickening, and this is attaching this
Oh,
tissue to the advena. That is mesorchium.
mesorchium, yes, sorry.
Mesorchium. And from the lower pole, as you described, there is a pull of thickening tissue. That is gubernaculum. Yes. So tell us the chronology of testicular descent from retroperitoneum up to the bottom of scrotum. What is the chronology?
So first, sir, there are phases of development. There's like three phases of descent. There's transabdominal and the transinguinal, and we also have extra canalicular descent. First, we have the hypothalamic pituitary axis, gonadal axis, and from here the androgens are involved in the descent of the testis from
Anti-Mullerian hormone. Androgen
yes,
and anti-Mullerian hormone. Mullerian
also
inhibiting substance.
anti-Mullerian hormone is secreted from
Sertoli cells. Hello.
no.
Mullerian inhibiting
Anti-Mullerian hormone that
Sertoli cells secrete estrogen. No, what? Am I wrong?
MIS.
Mullerian inhibiting hormones are important for male differentiation.
or rather disappearance of the female genital structure.
Yes.
Yeah. So what happens? A fourth thing start developing. At what interval it runs from retroperitoneum to the iliac fossa?
So from 8th to the 15th week, there is descent, and after that, from 10th to 25th weeks, there is a resting phase. And during this period,
What period? What period?
Sir, resting phase.
Which period you are saying?
Sir, 10th to 15 weeks.
No.
Sir, not 10, sir. After 15 weeks.
4 to 7 months. 4 to 7 months means 28 weeks. It is from the retroperitoneum up to the near the deep ring. There is a resting period of 7 to 8 months. That means 28 to 32 weeks. And then is the intercanalicular stage, 8 to 9 months. 8 to 9 months traverses the inguinal canal. At the end of 9 months, it is the bottom of the scrotum. So that is a normal chronology of descent.
Sir, do we have to mention the resting phase? I read it somewhere. Like there's a.
It is there. It is described in the anatomy book.
Yeah.
That this period it does not move.
15 to 20.
There is no harm. That is the usual chronology of descent.
Yes.
Madam, I think you have to go to hospital. We will stop here.
Yes. Okay. Thank you very much.
Thank you.
Thanks a lot.
Thank you, ma'am. Thank you. Thank you, Sritima. You answered well. Good.
Thank you.
Chalo.